Dr. Khan Mohammad Nangrejo, please join us on stage. Thank you very much, sir. Okay, since we have a short time, we have a limited time slot for every presenter. So I would like to tell that you have 6 minutes for your presentations. I will give you a bell in around 5 minutes. So our first presenter for today would be Dr. Amir Israr, and he'll be telling us about detection of keratoconus with newer biochemical index. Please, sir, I welcome you today.
Sir, Dr. Imtiaz, Amir Israr, sorry. Thank you so much. I'll be talking about the biomechanical indices that we calculate with Corvus is the main tool. To know about the biomechanics, we actually need to know how our cornea behaves to the external forces. There are two elements to it. One is the elasticity, the other one is the viscosity. There are quite a lot to talk about, but since this time is short, so I'll be just running through it pretty quickly. We have noticed that there have been cases in which we do all the tests and everything, but still find out that there are ectasias down the line, maybe 2-3 years, when we run into the test again, and we find that everything was pretty good, but still the ectasia popped up. Now, looking at those things, and there are like cases we see where all the tests were not good, there were more than 2 moderate signs, which were not actually, or we should not have attempted doing LASIK, but still they hold on pretty good. So there's like confusion, like which person or which patient to do refractive surgery on, or who's going to develop keratoconus or not, or ectasia or not. So when we look into it, there is certainly a single point of a biomechanical failure into the cornea, and that biomechanical failure point has to be detected. Now, when we look into different parts of the cornea to know which part is affected, initially, when we look at the slit lamp, by the time we diagnose that on a slit lamp that the keratoconus is present or not, it's a bit too late. So the idea is to detect this keratoconic changes way too quickly. And biomechanical indices by Corvus is like the newest one. Now, even the future to it is to know the biomechanics of Bowman's membrane, desmoid, stroma, epithelium, endothelium, every layer independently, and even dividing stroma into 3 different portions. And once we're there, then we might be able to predict who is going to develop a keratoconus or who's not going to develop a keratoconus. Now, when we look into the Corvus and find out where the keratoconus actually is going to lie in or not, it's more like a failure of the biomechanical indices which lead to the ectasia of the cornea. I'm just trying to rush through because 6 minutes is too short to basically talk about. Now, when we actually integrate the data from Pentacam into Corvus, that is where we actually get the proper thing. CBI alone might not be telling us the true story. We have to put the data in from Pentacam. That gives us a TBI. That will lead to a proper index. That will lead to the detection of those cases which might develop ectasia following refractive surgery or may develop a keratoconus afterwards. Now, if you look into this picture, I don't think so. I've got a pointer here. If the pointer is not working. So if you look into this picture, if I was to do my refractive surgery, I would be very much concerned about this area here, although all the biomechanical indices are coming normal. So initially when we got this Corvus, we thought like we are going to decrease the number of cases that we're going to attempt for refractive surgery, but actually it went the other way around. We were doing more cases because we started feeling more comfortable. Although the PTI and CTSP are normal, this is normal, and the biomechanical indices are normal, so we do not have a biomechanical failure index in the cornea. It is the anatomical change which would not have any effect even if we attempt for a refractive surgery. Now, this is a post-refractive surgery patient in which, just to show you that Corvus will never indicate anything right, as these are not virgin corneas, so do not rely on these corneas for giving you the biomechanical indices if there is anything done to the cornea before. The other important thing that we can measure with Corvus is the intraocular pressure, which basically is going to cancel out the biomechanical factors which influence the intraocular pressure. Now, in this case, we can see that there is quite a thick cornea. The intraocular pressure measured on a Goldman tonometer was 21, whereas BIOP is 17.4. So this is like quite a useful thing if we are confused in a thick cornea as for measuring of intraocular pressure. This is another case in which we found out that there is a bit of a tear-shaped deformity here, whether it is going to be a defect or we should go in for refractive surgery or not. And since all the indices were normal, so we carried out. Similar is the case when we actually looked into other pictures. I'll just go on to the, now let's talk about a little about our patient one, who's a 33-year-old male, came in with a right eye burning sensation, with a sticky eye, had halos and glare for 2 months, and was using different topical antibiotics and lubricants and was not getting anywhere. On a slit lamp examination, although this picture is not clear, we could see like small tiny opacities, and when we did a corneal densitometry, we could see some small opacities of adenoviral keratitis. Treatment was prescribed, and after that, almost like 4 weeks of treatment, we can see those things disappearing. These are multiple advantages when we have got a combination unit of Pentacam and Corvus, which actually solves out a lot of problems.
You have a minute left, Dr.
All right. Whenever you say, I'll stop. Now, we talk about our second patient, 23-year-old, 6 months, halos and glare. We can see like these opacities coming up. This is a post-PRK haze. Treatment was prescribed, corneal densitometry repeated, and the thing is much more settled. I will stop here and we'll intrude into other people's time. Thank you so much. Thank you.
Thank you very much, Dr. Amir Israr. It was indeed a very wonderful and informative session. Our next presenter would be Dr. Shahabul Hassan Siddiqui. He'll be presenting OCT interpretation of AMD.
Assalamu alaikum. Sorry. Okay, so today's topic is about how to read an OCT if someone is having age macular degeneration. Definitely, it's just introductory slides in which we are going to cover the dry macular degeneration and the wet macular degeneration. Just because of the shortage of time, I'm just skipping these 2 slides. If any OCT is thrown to me and I have to read it, there are different ways to read it. We can start it from the top, we can start it from the bottom, or another way is to start from a most hyporefractive. The hyporefractive mean any layer which is darker in color, and hyperrefractive mean which is anything which is brighter in color or more whiter in color. So we can start it to read from this layer, which is outer nuclear layer. The importance of this outer nuclear layer is that above to this layer is whole inner retina, and below to this is outer retina. These 4 lines are very, very important. The one is external limiting membrane, the another one is ISOS junction. ISOS junction is also known as ellipsoid zone if it falls just below the fovea. So this 3rd line, this is interdigitation zone. That is basically the resting of photoreceptors on RPE. And finally, this is not just RPE, it's a combination of 2 layers, RPE and the Bruch's membrane. So normally, if any OCT comes to me, I would directly jump onto this thing. Anything which is quite obvious or away from the normal. But for the beginners, try to read an OCT from where you can read all the lines perfectly. So if I'm going to read here, this is RPE, and I can see some bumpy, lumpy appearance. We can measure the size of these elevations, which are known as drusens. So this slide is very important as far as the size of drusen is concerned, as far as the visual complaint regarding drusen is concerned. So this one is smaller one, this one is a medium-sized one. Here we can see some hyperrefractive foci. This is nothing but the RPE migration, pigment migration. Usually the patient who are having drusen, they don't have any visual complaint. But if this happens, that is the disturbance in the photoreceptor layer, over here, the yellow marker showing, and the external limiting membrane, this means the vision is going to disturb in this patient. Other than this is a new term, comparatively a new term, in which we can see the RP is slightly elevated if this size is more than 1000 micron, and this elevation is less than 100 micron. This is known as SIRE, shallow, irregular RPE elevation. The importance of this is that this is considered as non-exudative macular neovascularization, means that there is neovascularization here, but we don't have any exudation. As we don't have any exudation, we can't really treat it. So, but this patient might end up into around, in roughly around 5 years period, it could 10% people can end up into wet macular degeneration. So we have to keep this patient under observation. We have to do OCT again after every 3 to 4 months. We have to give Amsler chart, a very important tool to assess the macular vision. So this is known as SIRE. Okay, so here we can see more signals are coming from here, because if we just follow the RPE is not here. So the RPE is not allowing, so the RPE is not in fact impeding the light which is coming from top to bottom. So this is known as posterior shadowing, hypertransmission, reverse shadowing. There's so many terms which can be used over here. So the importance of this RPE is damaged. Okay, the another term is pseudo-drusen. We all know that drusen lie at the level of RP or below the RP. If something which is present in the subretinal space and coming up and down and causing disturbance of overlying photoreceptor, this is known as pseudo-drusen. There are three types. One type is just the elevation of the mass which is aggregated over here. The stage 2 means it will just disturb the architecture of photoreceptor, but it will not disrupt it. In stage 3, you can see the photoreceptor is disrupted, and this may end up into wet macular degeneration as well. Okay, again follow the RP, follow the RP. The yellow line shows just something which is above the RP, and that is photoreceptors, ISS junction. This one is disrupted, and this RP is elevated, and here we can see mixed picture of reflectivity. This one is hyper, this one is hypo, this one is pure hyporeflective. That means that something is present in the subretinal space, and that is serous retinal detachment, subretinal fluid. But I would like to pay your attention over here that hyperreflectivity here is of two types. The hyper one is known as fibrous tissue, and this hypo could be a leaky one. So this is a classical picture of fibrovascular PD. The white arrow shows that I'll explain this white arrow in the other picture. That will be quite clear to you. Okay, this again, elevation of RPE. Something lies below the RPE, but a very well-defined hyperreflective thing. The well-defined hyperreflective thing, again, with some component of hyporeflective, this is hemorrhagic. This is hemorrhagic pigment epithelial detachment with subretinal fluid as well. Okay, this one is elevation, again, a very classical peaked elevation of pigment epithelium. But again, we have some red arrow which is showing hyperreflective time, a fusiform hyperreflective time. This is known as choroidal neovasal. And this yellow line is showing Bruch's membrane. I just mentioned earlier that the last hyperreflective signal is the combination of RPE and the Bruch's membrane. So here, the RPEs get separated from the Bruch's.
I'm sorry to interrupt you. You have a minute left.
Thank you. So again, okay, I'm skipping this up. This one. Remember 3 to 4 points for the junior, that if we have multiple PEDs, if we have large PED associated with small PED, if we have a notched PED, if we have any PED closer to disc, this is probably idiopathic, polypoidal, choroidal vasculopathy. And the another most important slide is this. I'm going to end up over here. We can see some hyporeflective sign here, and hyporeflexism here. The difference between both of them, this one is surrounded by a hyperrefractive window, and this one lies into the outer retina. This one lies into the inner retina. This one is rounded, this one is squared. This is known as outer retinal tubulation, and this is known as cystoid macular degeneration. Two important things. These are usually associated with underlying hyperrefractive thing. That means it is associated with scar. And we do not have to treat this hyporeflectivity. Thank you very much.
Thank you very much, Dr. Shahab. It was a very comprehensive and very informative session in OCT imaging. Our next presenter will be Dr. Arfa Hassan. She will be presenting three-dimensional analysis of neuroretinal rim thickness changes.
Good morning, Mr. Chairperson and all respected ophthalmologists. It's a matter of immense pleasure and honor to be invited by AICO 2024, and I am at the moment working with Dr. Afzal Bodla at Bodla Eye Care, which is Center of Excellence in Glaucoma Management and Research Center. My today's talk is on three-dimensional analysis of neuroretinal rim thickness as an important diagnostic criteria for open-angle glaucoma. Don't let glaucoma darken your life. So, let's have a brief interview about glaucoma. It is a neurodegenerative disorder and permanent cause of blindness. As neuroretinal rim loss is irreversible, so blindness caused by glaucoma is also irreversible. Death of RGCs involves thinning of retinal nerve fiber layer, macular ganglion cell complex, and neuroretinal rim tissue thickness. So, what is NRRR? It is a portion of optic nerve head which contains retinal ganglion cells. It plays an important role in maintaining vision, and it transmits visual information from retina to brain. There are some parameters. Neuroretinal rim width, normal size, 1.40 plus minus 0.186. And NRR changes start at 6 o'clock and 12 o'clock quadrant. And then changes begin in supratemporal quadrant, and then inferior temporal, and in inferior nasal, and then superior nasal quadrant. This is ISNT rule for RNFL thickness, superior, nasal, temporal, and inferior. Thinning of neuroretinal rim. As we all know, one early sign of glaucoma is thinning of neuroretinal rim at vertical poles, which results in elongation of vertical cup. So, how neuroretinal rim changes begin? As glaucoma progresses, neuroretinal rim area continuously diminishes. It is more evident in infratemporal part of NRR than in superior temporal part. NRR thickness at 6 o'clock position correlates with RNFL changes and is better indicator of glaucomatous ONH changes. So, NRR assessment appears to be a valuable method for diagnosing pre-perimetric glaucoma and glaucoma suspects. This is our ongoing study at Bodla Eye Care, and our purpose is to evaluate the diagnostic importance of neuroretinal rim and to assess progression in mild to moderate in 3D OCTs by OCT scans. Our study's selection criteria includes cases of pre-perimetric and glaucoma suspects, mild to moderate open-angle glaucoma, and exclusion criteria, advanced glaucomatous cupping. A patient presented at Bodla Eye Care, 35-year, having 5 diopter of myopia. These were the parameters. OCT analysis were rim area and RNFL normal in all quadrants. So this patient was on anti-glaucoma medication. We off medication on basis of normal rim and RNFL thickness in all quadrants. And his IOP is normal without medication after 3 months follow-up duration. So NRR should be a diagnostic parameter for the glaucoma detection. Same for left eye. This is case study 2, and same OCT ONH showing rim area changes and RNFL thickness in superior and inferior quadrant. So this is the OCT scan showing reduced thickness RNFL. Rim changes in a case of moderate open angle glaucoma observed. IOP of patient is stable on 2 drugs. Third case is patient came and his rim and RNFL showing progression in 6 months follow-up. Fundus photographs right eye, fundus photographs of left eye. And this is the OCT scan when patient came at the time of examination. His right eye rim was 1.30, left eye rim was 1.65. And after 6 months follow-up, his right rim was 1.19, CD ratio 0.70, and RNFL thickness also reduced in quadrants, inferior quadrant. Left rim remains same, 1.64. So this is conclusion. In third case, rim and RNFL progression in inferior quadrant observed. Right eye rim was 1.30 at time of examination, but after 6 months follow-up, it was 1.19. So despite of controlled IOP, rim changes are indicative of glaucoma progression. Right eye needs further lowering of IOP. Our study concludes that NRR changes are valuable in...
You have a minute left.
Okay. Pre-perimetric and glaucoma suspects and represent directly CP-RNFL and MGCC changes. We are relying on RNFL and MGCC thickness, but NRR also has nerve fiber layer, and changes in NRR thickness could be taken as one of important diagnostic criteria, as well progression and pre-perimetric and perimetric glaucoma. These are 10 commandments for glaucoma diagnosis. This NRR should be also a part of this. Thank you. Thanks to Dr. Afzal Bodla, who gave me opportunity to talk on this event, and for your guidance. Thank you so much.
Very good presentation, Dr. Arfa Hassan. Our next presenter will be Dr. Afshan Ali, and she'll be talking about transscleral diode laser complication. Do we have Dr. Afshan Ali here? Dr. Afshan Ali. Okay, so I think she's not here. Our next presenter would be Dr. Zia Mazhari to tell us about the role of anterior segment OCT in diagnosis and treatment. Dr. Zia Mazhari, do we have us? No. Okay, so our last presenter would be Dr. Zubaida Sirang, and she will be telling us about hub and spoke model in ophthalmology.
Thank you so much, everyone. My name is Zubaida Sirang, and I'm currently working with the Khan Health Service Pakistan. So I'll be talking about hub and spoke model in ophthalmology that has been recently introduced in Pakistan. So first we'll talk about hub and spoke model and how it's integrated in the healthcare system. It's kind of a system that has an anchor, that is the main establishment, that is known as hub. And then there are secondary establishments that are known as spokes. Why it is introduced into healthcare? Because it maximizes efficiency and effectiveness, and it needs lesser human resource to reach far-flung areas. So we introduced, when I came back from Dublin in 2020, we introduced this in Gilgit-Baltistan and Chitral region under Khan Health Service Pakistan. That is a not-for-profit organization that's working in different countries. It's a global organization. The aim was to serve the far-flung areas and the people of far-flung areas with the limited resource available. And hence, we introduced this model here in our part of the world. I'll just give you a little scenario of how we do it. We integrated with the community through this Ilaj app Asan program, and we also send our optomes to different parts of the community for screening in the far-flung areas. And then there are basic health centers that are located in different villages where lady health workers or lady health visitors are working, and we try to train them in basic eye screening or basic eye treatment, like how to treat red eye and how to refer the patient that requires refer. And then we have health centers that are located in various establishments where we have put our optometrists who are trained to do the basic eye treatment. And then we have the medical centers. In the medical centers, we have the ophthalmologists that are the main hubs. So the ophthalmologists are basically connected to the optomes. The optomes are connected to the lady health workers, and then those are connected to the community so that we can serve maximum people, the underserved people with limited resource that is available. And then we are connected to Khan University Hospital, Karachi through our medical center. This is how we work. So the main hub is the Ahan Medical Center Buni, that is located in Chitral, and Ahan Medical Center Gilgit, that is located in Gilgit, that are like 46 and 37 bed secondary healthcare centers. Then they are fully equipped with state-of-the-art facilities like OCT and biometry and other things that have been introduced for the first time in the northern region. Then we have the sub-hubs that I talked about. We have optoms doing the day-to-day clinics, and if the patients require referral or require surgery, they are referred to the hubs. And then we have the spokes where the basic health units where the optoms would be visiting maybe once a week or once in 2 weeks to do the screening, and the nurses are trained to do the basic eye clinics. And with the community, we are connected via Ilaj Asan app, and also we do the community screening program as well. What has been the impact? It has been wonderful so far. So far, we have been able to do the 10,000 screening programs so far, in which 30% of the patients have undergone various surgeries, including cataract surgery, and some people have been facilitated with various NGO and other things. And then under the sub-hubs, we see 20-25 patients daily by the optoms and the nurses. And the hubs, we have the state-of-the-art ophthalmic facility where we do regular surgeries and clinics. And this is how we do it. And Ilaj Asan is the app which we use for the community screening and to reach the community. Thank you so much.
Very well presented, Dr. Zubaida. Thank you very much. So now I would like Dr. Khan Mohammad Nangrejo to speak few words of appreciation and ask any questions from the audience and to our presenters.
Bismillahirrahmanirrahim. This session is only on the diagnostic, and diagnostic is important in order to diagnose the, and particularly nowadays the OCT. OCT. What about the macular edema and drusen's, and what are the importance of the drusen's in AMD, and also diagnosis in the early diagnosis of the glaucoma. So, can you, Siddiqui Saab, can you, अच्छा, Mazari Saab का topic जो है, जी.
Dr. Zia Mazari. Okay, so we have Dr. Zia Mazari here. Thank you so much, sir, for coming. You have the presentation, role of anterior segment OCT in diagnosis and treatment.
बिस्मिल्लाहिर्रहमानिर्रहीम। तो ओसीटी का हमने रेटिना में और ग्लाकोमा के डायग्नोसिस में रोल तो एस्टेब्लिश है, तो इट हैज़ एन एक्साइटिंग इंक्रीजिंग इंडिकेशंस इन इंटीरियर सेगमेंट एज वेल. सो लेट्स सी what we can do and what are the potentials which can help in establishing diagnosis and planning anterior segment disorders management. So what can it image? It can give you details of tear film, cornea, conjunctiva, sclera, angle, anterior chamber and lens. So whatever you can see on slit lamp, the OCT can also scan that. And it can document and quantify that. Scan modes different होते हैं, जैसे रेटिना में हैं 30 to 60 स्कैन कर सकते हैं, थोड़े स्कैन करें और क्वालिटी को हाई रखें, तो ये मशीन टू मशीन वेरिएबल्स हैं. हमारा अपना जो ज़्यादा एक्सपीरियंस है वो नाइडेक के इंटीरियर सेगमेंट मॉड्यूल के साथ है, RS3000. पोजीशनल चेंज से और जो आप स्कैन को काट रहे हैं लाइट से भी, तो आपको पता है वो स्लिट लैम्प को स्लिट की वजह से कहते हैं, एंड दैट मेकिंग अ स्लिट गॉड गलस्ट्रैंड द नोबेल प्राइज. एंड दैट्स हाउ द ऑप्थेल्मोलॉजिस्ट डिफर फ्रॉम अदर स्पेशलिटीज, फ्रॉम फिजिशियन एंड सर्जन्स. वी डायग्नोज द डिसऑर्डर्स एट माइक्रोस्कोपिक लेवल, एट हिस्टोलॉजिकल लेवल. With this great invention of slit lamp, we can divide the eye into optical sections, and at cellular level we diagnose. That's why, alhamdulillah, if we are able to spend a little time, we are so accurate as ophthalmologists. And similarly, the optical section light कर सकती है, तो OCT beam भी उसी तरह sections कर सकती है, vertical, oblique, horizontal, जोन सी structure जहाँ से आप देखना चाहें, but you have to spend time. तो ग्राफिकल प्रेजेंटेशन में ये जैसे MRI में होता है, वाइट ऑन ब्लैक, T1 और T2 वेटेड इमेजेस, तो ये वाली डिवीजन OCT में भी पॉसिबल है, ब्लैक एंड वाइट ऑन ब्लैक. और लेयर्स बिल्कुल उसी तरह हैं जैसे आप क्लासिकली हिस्टोलॉजी की पिक्चर्स में देखते हैं. टियर फिल्म, एपिथेलियम, बोमेन्स मेम्ब्रेन, स्ट्रोमा, डेस्मेज और एंडोथेलियम. और इन सब के डिसऑर्डर्स को आप अलग-अलग क्लासिफाई कर सकते हैं, क्वांटिफाई कर सकते हैं. 44 years old फीमेल, और इसमें बहुत सारी स्लाइड्स हमारे बड़े हाशमानी साहब के बड़े प्रॉमिसिंग साहबजादे नुमान हाशमानी ने प्रोवाइड किए हैं हमें. हमने असल में लाहौर में एक कॉम्प्रिहेंसिव कोर्स किया था, डीकोडिंग OCT. उसमें इंटीरियर सेगमेंट भी था और पोस्टीरियर सेगमेंट भी था और एंजियो OCT भी था. तो उसका ये एक हिस्सा था इंटीरियर सेगमेंट OCT. तो मैंने नुमान की इजाज़त से उसके केसेस भी इसमें शामिल किए हैं और हमारे अपने केसेस भी शामिल हैं. तो 44 years old female came with complaint of gradual decrease in vision. There was no known comorbidities. अब ये OCT का स्कैन है, देखें ये एक बुल्ली बना हुआ है यहाँ पे, और नीचे देखें आपको एंडोथेलियम जो है वो इर्रेगुलर, और वो जो क्लासिकल आप गटैट शेप देखते हैं, सैंड पेपर लाइक अपीयरेंस, वो आपको एंडोथेलियम में नज़र आ रही है. तो ये फ्यूक्स एंडोथेलियल डिस्ट्रॉफी का पेशेंट था, ये वाला. उसी का देखें एक ज़्यादा एडवांस्ड केस है. अब एडीमा की वजह से कॉर्नियल थिकनेस भी बढ़ गई है, और एंडोथेलियम का देखें क्या हाल हो गया बिकॉज ऑफ द एडीमा एंड एंडोथेलियल मैल फंक्शन. So this is advanced Fuchs endothelial dystrophy. 22 years old male came with complaint of decrease in vision. ये उसकी टोपोग्राफी है, और ये देखें टोपोग्राफी में आप देख रहे हैं ये नीचे ये हॉटस्पॉट है, थिनिंग का एरिया है, और इस चीज़ को OCT का जब आप वर्टिकल स्कैन करेंगे तो यूं नज़र आएगा. तो डायग्नोसिस क्या है? पेरिफेरल थिनिंग है, और ये पैलोसिड मार्जिनल डीजनरेशन है. 22 years old male went for LASIK surgery and came up back with hand motion vision. अब उसका जो सारी स्कैनिंग की है, स्टीरॉयड वगैरह उसको दे रहे हैं, कोई और abnormality नहीं है. एपिथेलियल मैपिंग जो एपिथेलियल थिकनेस को मैप करती है shows excellent epithelial contours. There is no problem here. And what does OCT show? This is the flap, and this is interface. This is interface fluid accumulation detected on corneal OCT. This was the reason of decreased vision. Interface fluid syndrome, pressure-induced stromal keratitis. नंबर 4 पे है, एक 42 years old female underwent bilateral cataract extraction implanted with pan-optic trifocal lens. एक हफ्ते बाद वो शदीद फोटोफोबिया के साथ आई हैं, और जो सुबह होता है और शाम तक बेहतर हो जाता है. ये प्लेसिडो डिस्क एनालिसिस है जिसमें कोई ख़ास abnormality नहीं है, और यहाँ पे आप थोड़ा सा देख रहे हैं टियो फिल्म ब्रेक हो रही है. और ये नॉर्मल इमेज है. अगर आपको इसके OCT के डायग्नोसिस में कन्फ्यूजन हो तो हमेशा एक तरफ नॉर्मल OCT का ब्लैक एंड वाइट और वाइट ऑन ब्लैक इमेज रख लें और उसको कंपेयर कर लें. तो ये देखें, ये इंफीरियर, सॉरी गलत बटन दब गया. तो इंफीरियर जो कॉर्निया है उसमें थिनिंग हो रही है. डायग्नोसिस recurrent corneal erosion syndrome secondary to Bowman's layer dystrophy. तो डायग्नोज क्या करेंगे, बैंडेज लेंथ लगा दीजिए और सोडियम हाइलोरोनेट ड्रॉप्स दे दिए और जेल दे दी और अल्हम्दुलिल्लाह द पेशेंट सेटल्ड। 14 साल का बच्चा है, वो हमारे पास आया फॉर सेकंड ओपिनियन अबाउट CXL। उसको ऑयल ड्रॉपलेट साइन देखा और उसकी बुनियाद पे उन्होंने केराटोकोनस का डायग्नोज करके और एक प्रोविजनल सा डायग्नोसिस उसको दे दिया कि आपको मखरूती कार्निया है, आप आना, आपके बाकी टेस्ट करेंगे और आपको लेज़र लगाएंगे। तो वो घबराए हुए जब हमारे पास आए तो हमने देखा कि डिस्टेंट डायरेक्ट ऑप्थेल्मोस्कोपी पे ऑयल ड्रॉपलेट साइन तो था, लेकिन जब हमने उसको स्लिट लैम्प पे भी स्कैन किया तो मैंने देखा कॉर्निया तो नॉर्मल है, तो इसके लेंस की शेप कुछ एबनॉर्मल है। तो ये डायग्नोज हुआ एंटीरियर लेंटिकोनस। थोड़ा ही रह गया है, जितने कहोगे बंद कर देंगे। तो बस वी स्टॉप हियर, स्टार्ट द डिस्कशन।
ये है कि जिस तरह विनोद जो है ना, हम कैटेड सर्जरी करते हैं और कार्निया को देखते हैं, तो काउंट 700 इज मेंटेन द ट्रांसपेरेंसी ऑफ द कॉर्निया। ये जो है ना, आप एंडोथेलियम काउंट जो है 900 हो, 800 हो तो थ्रेट होता है कि डिकम्पोजिशन चला जाएगा। ये OCT में हम कुछ मिल सकता है इसमें?
OCT तो आपको इनडायरेक्ट एविडेंस देगा, उसके लिए तो आइडियल टेस्ट स्पेकुलर माइक्रोस्कोपी है। लेकिन शॉर्ट ऑफ दैट एक हमारे बचपन का टेस्ट है जो तारक सईद साहब हमें सिखाते होते थे, दैट्स नोन एज स्पेकुलर रिफ्लेक्शन टेस्ट। ये स्पेकुलर माइक्रोस्कोपी और स्पेकुलर रिफ्लेक्शन टेस्ट आर बेस्ड ऑन फर्स्ट लॉ ऑफ रिफ्लेक्शन, व्हेन द एंगल ऑफ इंसिडेंस इज इक्वल टू एंगल ऑफ रिफ्लेक्शन, द मैक्सिमम रिफ्लेक्शन अकर्स। तो अगर आप पेशेंट का विजुअल एक्सिस बाइसेक्ट कर दे आपकी इल्यूमिनेशन बीम और व्यूइंग माइक्रोस्कोप के एंगल को, दैट्स हाउ यू गेट द इमेज ऑफ द एंडोथेलियम। तो आप एमिंग बीम और उसको इस तरह से अलाइन करें कि आपका जो पेशेंट का विजुअल एक्सिस है उसको बाइसेक्ट करे और हाई इल्यूमिनेशन में और ब्राइट इल्यूमिनेशन में एंडोथेलियम पे फोकस करें, तो वो जो गटाटा की अपीयरेंस है 1000 के बिलो, वो आपको क्लिनिकली मिल जाएगी और उसको OCT कंफर्म कर देगा। लेकिन उसका जो एब्सोल्यूट टेस्ट है काउंटिंग का, दैट इज स्पेकुलर रिफ्लेक्शन टेस्ट।
Thank you very much, Dr. Zia. Any other questions from the audience? Okay. 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 Dr. Hassan Sajid has joined us. Thank you so much to co-chair us for this session. And we had this session of diagnostics today, sir. Okay. I have a question from Dr. Shahab.
Excuse me, अगर मजहरी साहब के पास टाइम आपके पास है तो मजहरी साहब को कंटिन्यू रखने दे। मेरा रिक्वेस्ट है कि उसके जो बाकी स्लाइड है वो हमें बता दे।
ये स्पेशल रिक्वेस्ट पे है तो हम इसको डिनाई नहीं करेंगे। प्लीज़ डॉक्टर ज़िया कंटिन्यू दिस सेशन एंड आई विल गिव यू अनदर 4 minutes टू कंटिन्यू प्लीज़।
आई विल बी क्विक ताकि ज़्यादा बॉदरेशन ना हो। स्लाइड्स तो ये देखें, ये कितना इंटरेस्टिंग और ख़ूबसूरत डायग्नोसिस किया OCT ने। दिस इज़ एंटीरियर लेंटिकोनस। और उस बच्चे को जब हमने वर्कअप किया तो उसको नेफ्राइटिस भी था और उसका एक भाई नेफ्राइटिस की वजह से एक्सपायर्ड एज वेल। तो अल्टीमेटली हमने उसको वर्कअप करके सारा डायग्नोज किया और उसकी फिर एक वीडियो बना के अमेरिकन एकेडमी ऑफ ऑप्थेल्मोलॉजी को भी भेजी, तो दे आल्सो एक्सेप्टेड इट। और वो पूरा जो केस है एज अ केस रिपोर्ट अमेरिकन एकेडमी ऑफ ऑप्थेल्मोलॉजी के ONE नेटवर्क पे इस वक्त अवेलेबल है। सो लिटिल हार्ड वर्क। फिर हमने क्या किया, फिर हमने उसका कैटरैक्ट निकाला, तो वो जो 660 और अकाउंटिंग फिंगर विजन थी, माशाल्लाह ही 6'9" नाउ एंड एन्जॉइंग अ नॉर्मल हेल्दी विजन। और दूसरा हमने उसको सेंसिटाइज कर दिया अबाउट नेफ्राइटिस, तो अब वो नेफ्रोलॉजिस्ट के साथ भी इन कनेक्शन है। ये रीज बकलर्स डिस्ट्रोफी है उसमें जस्ट आपको शो करने के लिए कि दिस इज़ हाउ इट लुक्स ऑन ओसीटी। और इसका ओसीटी का ये फ़ायदा है कि इससे आप पीटीके प्लान कर सकते हैं, थेराप्यूटिक एब्लेशन। तो यहाँ से हमने उसका टोटल थिकनेस भी मेजर कर ली और मुख्तलिफ पॉइंट्स पे उसकी थिकनेस देख ली कि वो जो हमारी ओपेसिटीज़ हैं उनका साइज़ क्या है, और उससे हमने डेप्थ ऑफ एब्लेशन प्लान कर ली। और अभी डॉक्टर शहबाज साहब के साथ उनकी स्टूडेंट और हमारी बेटी बैठी हैं लाइबा, तो मुस्कुरा रही हैं। तो इस सारी काविश में डॉक्टर लाइबा और डॉक्टर अब्दुल्ला का बहुत हाथ है। इन्होंने इस सारी जो स्लाइड्स हैं और उनको डॉक्यूमेंट करना और उनको प्रेजेंटेबल शेप में बनाने में इन दोनों बच्चों ने बहुत किरदार अदा किया है। और हम शहबाज साहब के भी मशकूर हैं, माशाल्लाह, पैटर्नाइजिंग द स्टूडेंट्स सो वेल। तो ये बायलेटरल सब एपिथेलियल डिपॉजिट हैं, रीज बकलर डिस्ट्रॉफी है। और उसी ओसीटी की गाइडेंस में जब हमने एब्लेशन की तो ये देखें, ये माशाल्लाह उसका विजुअल एक्सिस क्लियर हो गया और वो अभी 2 साल का हमारे फॉलोअप में है और वो लड़का अभी सऊदीया में माशाल्लाह जॉब कर रहा है। तो दिस इज़ हाउ यू कैन हेल्प एंड दिस इज़ हाउ ओसीटी कैन मेक यू मोर एक्यूरेट इन प्लानिंग एंड एक्सरसाइज ऑफ योर प्लान्स। तो ये क्लासिकल मनसन साइन देख रहे हैं आप क्रेटोकोनस का, और दिस इज़ हाउ इट लुक्स ऑन ओसीटी। बहुत ज़्यादा इंटीरियर चैम्बर डेप्थ है और कोनिकल कॉर्निया है और वहाँ पॉइंटेड आउट कॉर्नियल थिनिंग है। 52 साल का बंदा है, डिक्लाइनिंग वीएन, ACIOL इन प्लेस, और ये ACIOL इंड्यूस्ड बुल्लस क्रेटोपैथी है। कॉर्निया की थिकनेस बढ़ी हुई है, बुल्ली बने हुए हैं, एपिथेलियल इरेगुलरिटीज़ हैं और डेस्मिस मेम्ब्रेन की भी इरेगुलर शेप और कंटूर आपको नज़र आ रहा है। ACIOL इंड्यूस्ड बुल्लस क्रेटोपैथी। और फिर ACIOL में OCT में ये ब्यूटी है कि यू कैन मेजर द एंगल विद नॉन इन्वेजिव टेक्निक। ये भी मशीन टू मशीन वेरी करता है और अभी एक्साइटिंग स्पेशलिटी है। हमने अपनी मशीन को तो स्टैंडर्डाइज कर लिया है और उसको हमारे ये बच्चे और असिस्टेंट जो हैं वो मेजर कर लेते हैं। तो 30 से ऊपर हो तो समझे ओपन एंगल है, और 20 से 30 डिग्री OCT डॉक्यूमेंट करे तो वो क्लोजेबल है, और 20 से नीचे है तो नैरो है। और ये हमारी बहुत हेल्प करता है, नॉन इन्वेजिव मेथड है गोनियो डॉक्यूमेंटेशन का, और आप अपनी पेरिफेरल एरोडोटमीज इसकी बुनियाद पे प्लान और डॉक्यूमेंट कर सकते हैं। और इन फ्यूचर हमारा यही प्लान है कि प्री लेज़र कर लेंगे OCT और पोस्ट लेज़र OCT करके भी डॉक्यूमेंट करेंगे कि कितने डिग्री का पेशेंट को बेनिफिट हुआ। तो फ्यूचर प्रॉस्पेक्ट्स में ये बड़ा एक्साइटिंग है जिसको अभी स्टैंडर्डाइज किया जा रहा है। ब्लैब मॉर्फोलॉजी पे OCT आपको बहुत यूजफुल इंफॉर्मेशन दे सकता है। इसके ऊपर मल्टी सेंटर ट्रायल भी चल रहे हैं और इसके ऊपर काफ़ी सोच विचार और फिलोसॉफिकल थिंकिंग हो रही है, और हम भी इसमें लगे हुए हैं कि जो मुख्तलिफ शेप्स आती हैं उनको कैसे क्लासिफाई किया जाए और कैसे स्टैंडर्डाइज्ड वर्टिकल और हॉरिजॉन्टल सेक्शंस लिए जाएं कि ब्लैब की मॉर्फोलॉजी को एनालाइज करते हुए हम इंटरवेंशंस को प्लान कर सकें। और ये बहुत एक्साइटिंग फ्रंट होगा इन कमिंग फ्यूचर with the help of OCT. Thank you very much for giving your patience and thank you Dr. Nangrejo for calling me back. वरना तो फिर अधूरी रह जानी थी आरजू। ज़माना बड़े शौक से सुन रहा था, हम ही सो गए दास्तां कहते कहते।
Thank you very much, Dr. Zia. Zabardast. It was an excellent presentation. And okay, I have a question for Dr. Shahab. Dr. Shahab, आपने pseudodrusen की बात की. So how to differentiate in pseudodrusen and drusen on OCT imaging? Plus also tell us that will it misguide us? अगर हम pseudodrusen देख रहे हैं तो क्या वो हमें misguide कर सकता है towards the diagnosis of macular degenerations? Yeah, you can do that.
Okay, sure.
Or you can just explain it.
Actually, the differentiation would be the place of the hyperrefractive signal. Normally, the histopathology of drusen is that it lies below the RP. It is basically the waste product of the excreta of the RP that lies below the RP and between the Bruch's membrane as well. So if something which is present in the subretinal space, that is the space between the RP and the neurosensory retina, and we have a hyperrefractive signal over there. So that would be a differentiating point. So if the slide will be there, that will be easier for you to make it understand. Okay, in this slide you can see that something, again I'm going to repeat the layers. External limiting one, this one is ISOS, and this one is the RPE Brooks membrane combination. So we can see this undulation, this bumpy, this speed breaker appearance, which is basically originating from the RPE. So this is the subretinal space. If you can see, this is subretinal space. I'm just highlighting this one. So if something comes from here, so that is a pseudodrusen. And you can compare it with here again. The RPE is elevated. This one is a bigger one. And so, and better than this, this is the one. So here, we have some hyper-reflective signals over here. It's above the RP. This is the one. This is the one. Again, this is the one, which is bisecting the ISOS junction. This is the type 3 one, pseudodrusen. So if we have something in this subretinal space, this darker space, that is a pseudodrusen one. Thank you.
Thank you very much, Dr. Shahab.
Thank you. My question from the Dr. Bodra Saab. Sir, Bodra Saab, you know that we have put periods was the perimetry. About 30% loss of perimetry give the kilo of the glaucoma. Now it's OCT. So we pick the glaucoma earlier and OCT. What are the criteria? We pick the early glaucoma and OCT.
Thank you very much. Practically, there are a lot of changes which has come with the time in the diagnosis, and especially with OCT and OCTA. One thing I would like to clear that the maximum concentration of the retinal ganglion cell, that is at the macula, and that is more than 50 to 55%. And macula is exactly the direct representation of the retinal ganglion cells. As far as the optic nerve head is concerned, optic nerve head is indirect extension, and that is optic nerve head is termination of the retinal ganglion cell, but that is the indirect representation of the retinal ganglion cells. So first, when we are referring any patient for the analysis of the retinal nerve fiber layer thickness, this is not only the optic nerve head, but the macular ganglion cell that has to be added. In our presentation today, the main thing was the retinal rim. So we are excluding the retinal rim at the moment, and we are only taking the optic nerve head analysis, that is the circumpapillary nerve fiber layer thickness. That is not the main thing. Sometimes the changes start at the optic nerve head, sometimes the changes start at the macular ganglion cell complex. So parallel, we have to have both analysis, the optic nerve head and the macular ganglion cell complex. And as far as the nerve rim is concerned, that has now come the most important. So if we want to truly diagnose the case, and especially the early glaucoma, the glaucoma suspect, the pre-perimetric glaucoma, we will have to undergo the 3 investigations: the optic nerve head analysis, macular ganglion cell, and the nerve rim changes. In the last, we gave it in the form of the 10 commandments. Basically, that is the actual way we can have the diagnosis of the pre-perimetric and perimetric glaucoma. And as you were saying, this is a more than 25% to 30% damage to the retinal ganglion cell when the perimetry will become positive.
Any question from the audience? Now, session The speakers are sitting here now. So, conclude. Now, let's conclude the session. Thank you very much. Today, diagnostic. Yeah, now I invite the speakers for the shield awarding.
Okay, this shield is distributed to Dr. Afzal Bodla. Thank you very much. Our next shield will be given to Dr. Shahab Ul Hassan Siddiqui. This shield will be given to Dr. Zia. Let's finish. Thank you very much. Thank you very much.